Welcome to the very first part of my National Board review. This is going to be my first time making these videos, so kind of bear with me with like the quality and like the whole recording aspects of it. It's not going to be very professional, but I am here to kind of help you guys out with studying for the board since there is a lot of information to cover. So obviously I'll be going over the topics covered on the board, but more so focusing on the high yield topics that you will definitely be tested on and questions that you will see on the board. I would still recommend whatever study material you're using, whether that's Darby or a board review book, okay, to kind of dive into the whole book and to understand what they want you to understand. But I'm just going to be going through my experience of the board and covering topics that I know that you will for sure see when taking the exam itself. So, part one, we're going to go over radiology. I feel like, obviously, on everyone's board, radiology is going to be a huge topic covered, and it's going to be very important to understand and to remember the information covered in radiology. And so, we can go ahead and get started. So the first topic I kind of want to go over is just identifying cavities when looking at like x-rays. This is an important topic to understand because this is what we're kind of going to be looking out for when you are in practice. Obviously, we cannot do the diagnosing of the cavities, but just noting of suspicious areas that you want your doctor to look at is very important. And so there are different types of cavities to know and to understand. And so they're going to go from incipient, moderate, advanced, and severe caries, okay? So the first stage is going to be incipient, okay? The cavity is going to penetrate through the enamel surface, but it's not going to go more than halfway through the enamel surface, if that makes sense, okay? It's going to stop less than halfway through. Okay. Next stage is going to be moderate caries. Okay. Moderate caries is penetration through the enamel surface, and you're more than halfway through the surface of the enamel. Okay. But you have not yet reached the dentin. That's the important part. Okay. And that's kind of the opposite for advanced caries. You've punctured all the way through the enamel surface until you've reached the dentin. Okay, you have now contacted the dentin, but you're less than halfway towards the pulp. And for severe caries, right, it's going to be the worst kind. You've punctured all the way through the enamel surface and more than halfway through the surface of the dentin, and you're actually heading towards, or you're actually at the pulp. And so kind of understanding, looking at panos, looking at bite wings, identifying caries that way will be very beneficial. And obviously knowing like the tooth number, okay, that the cavity is on, okay, is going to be important as well. And so these are the different types of caries to kind of know and understand. Another important part is just to know your restorations and what they look like, be able to pinpoint them out. If there's an arrow pointed to a certain restoration, being able to identify it, okay, is important. Most of these you guys already know, okay? You guys know what composite restoration looks like, amalgam, okay? Stainless steel, okay? Crowns, okay? Specifically, for crowns, make sure you look at the intraoral images that they give you, specifically in the case study portion, okay? Because if they give you like a bite wing, and let's say there's a crown on number 18, and one of the answer choices is like a gold crown, you won't know it's a gold crown until you look at the intraoral images. You won't know the type of material the crown is made out of just on the bite wing itself. So kind of keep that in mind. Teeth that have been root canaled will have gutta percha or silver points. Okay, identifying bridges and its structures. Okay, also known as pontics or their abutments, and also just identifying implants, which I feel like, I mean, that's pretty self-explanatory, okay? And the different kinds of implants as well, okay? Your endosteal implant is going to be the most common type of implant that we see, okay? But there are also subperiosteal and transosteal implants. And so on the next slide, I kind of have some pictures of these restorations, and just being able to pinpoint them out is important. So the most radio opaque structure, okay, restoration that you will probably see, okay, is going to be an amalgam filling. And so this is an amalgam filling right here. This is also an amalgam filling, huge amalgam filling, and another amalgam filling here as well, if you guys see my cursor, okay? All these are amalgam fillings, very radiopaque. Now, for composite restorations are also going to be radiopaque, okay? But it's not going to be as bright white as the amalgam fillings, okay? It's going to be more of like a kind of milky color, I guess. So this is a composite restoration here in A. I believe this is also a composite restoration as well. Okay, it's going to be just less white than these amalgam fillings. And here's a huge composite restoration here. I don't know if you guys can see this one, but that's also a composite restoration. And then taking a look at C, here's an obvious crown, right? It's going to replace the crown of the tooth, okay? It can also be called a cap as well. Some patients may refer to it as a cap. Okay, so here's a crown. Now, to my point, like I said before, we don't know what kind of material this crown was made out of, okay? This could be a gold crown. Based on the x-ray, we have no idea, so make sure you look at the intraoral imaging to determine what kind of material this crown was made out of. Now, for this specific type of crown, okay, it's pretty obvious what this is. This is a PFM, a porcelain fused to metal, okay? You can still see some of the tooth structure here, okay? And it kind of looks like a hat. That's kind of what I think about when I see PFMs, okay? They all pretty much look the same, I would say. So here's a PFM, here's another PFM, okay? And here's a PFM in A as well. And it looks like there may be a post in this tooth. That's either a post or this tooth has been root canaled. I can't really tell based on the bite wing, but if there was a PA of this image, a PA of this tooth, then it will be a lot easier to tell. Here's an example of a bridge, okay? And be able to identify, the structures of the bridge as well, okay? So in the middle, okay, the tooth that the bridge replaces, okay, that's going to be called the pontic, okay? The pontic, also known as just the fake tooth, okay? So we're replacing, okay, number 14, okay, in the upper left, okay? So this is a pontic, and then next to the pontic are going to be what's called the abutments, okay? So you have an abutment on the second premolar here, and then you have another abutment on the second molar as well. Going down here to this restoration, this is a stainless steel crown, okay? This is going to be like the most obvious one, because it looks so much different than the other ones. It'll be pretty easy to determine what this is, okay? It's like, it gives like a ghost-like appearance, and it's like the most 3D one out of all the restorations. So this is what a stainless steel crown looks like, and this is going to be the most common, or the most used in like children, okay? This type of restoration, the stainless steel crown. And here is another example, or an example of a tooth that has been root canaled with gutta percha. So typically in teeth that have been root canaled, they're going to have a cap or a crown on top of it, because you have taken away all the underlying tissue in the tooth, so the tooth is now very brittle, and so now a cap may be placed on there to kind of support biting and chewing and all that. And then here we have an implant supported bridge. So this is an example of an endosteal implant, okay? Typically made out of titanium, okay? And then you're going to have, like I said, the pontic, which is going to be the fake tooth in the middle here. So, endosteal implants, like I said before, you have other types of implants, right, such as subperiosteal, which you basically have like a framework where you remove like the gums and then you place this framework on top of the whole bone itself. That's what a subperiosteal implant is. And then you have a transosteal, trans meaning like going through, and so you're going through the whole mandible, and so that's what a transosteal implant would be. And so endosteal is going to be the most common that you're going to see. And also just identifying like recurrent caries as well is also very important, right? This looks pretty radiolucent under this filling here, okay? And also here are some radiolucent lines as well, and so these would be examples of recurrent decay or under a restoration, okay? Understanding radiographic errors. And so when you're taking a bite wing, obviously you want to open up the contacts. You don't want overlap. Okay, overlap means you have incorrect horizontal angulation. So wherever you place the sensor, okay, we want the beam to go right through the contacts of those teeth. So for example, this is an open contact, okay? The beam is perpendicular to the sensor and the tooth, okay? So creating that wide open contact, okay? So if you have incorrect horizontal angulation, if you're moving it, okay, either too mesially or too distally, okay, you're going to have overlap of the premolars or the molars, okay? Now, specifically for taking PAs, you may get foreshortening or elongation, okay? So foreshortening meaning the tooth looks a lot smaller than it actually is. And so if you think about it, the way this works is, it makes a lot of sense, okay? So for foreshortening, you have excessive vertical angulation. And so let's say like this is the tooth right here, and then this is your x-ray tube. If you increase the vertical angulation too much, okay, the tooth and the roots can be now stacked on top of each other, okay, and you're not going to see much of that root anymore, if that makes sense, okay? So too much vertical angulation results in foreshortening of the tooth, making the tooth look a lot shorter than it is. And obviously for elongation, it's going to be the opposite, right? So the elongation, the tooth's going to look longer than it may actually be, and that's due to inadequate, okay, vertical angulation. And so what you want to do is increase it a little bit, okay, to make it shorter, okay? So these are definitely opposites of each other. And then you guys know what a cone cut is, right? If you don't align the PID, okay, directly, okay, with that sensor, if it's not perpendicular, right, then you're gonna get a huge cone cut, and it's just obviously gonna be very radiopaque. You're not gonna be able to see anything in the image. So identifying those is important, and understanding what causes them is also important. Understanding panoramic errors can be a little bit more confusing than like the PAs or the bite wings. So to start off, right, understanding what the focal trough is. So the focal trough is just this U-shaped structure, okay, where you want your patient to be in to create the most diagnostic image, okay? So you don't want their mandible or their mouth to be too far in front or too far behind the focal trough, okay? And an error in this is going to both blur the anterior teeth, and it's either going to make them more narrow or make them a lot larger. And so if your patient is too far forwards in front of this focal trough, okay, the anterior teeth are going to end up being more narrow, okay, because you're too close, you're too far in front of that trough. Now, if you're standing behind that focal trough, okay, the anterior teeth are also going to be very blurred, but they're going to look more magnified, okay, they're going to look bigger. Now the Frankfurt plane is also a very important anatomical position to understand. Essentially, you want to line up the mandible as parallel to the floor as you can, and then this is where you guys kind of set up like the the tragus line to like the ala of the nose, okay, making sure that's parallel to the floor as well, okay. You're making sure that the Frankfurt plane is in, the patient is in the correct Frankfurt plane. That's essentially what that is saying, okay. So if the patient's chin is too low, okay, so if their plane is like this, okay, their pano is going to come out looking like they're smiling, okay? You're going to have an exaggerated smile, okay? Like the Joker smile, okay? But if the patient's chin is too high, right? If their plane is here while the floor is here, okay? You're going to have a reverse smile or just a frown appearance. And then you have other areas as well, such as lead apron artifacts, okay? If the patient is slouching and the vertebrae isn't all the way straight, or if they're not standing tall, okay, that's another error. And also just air spaces, specifically the palmoglossal air space as well. So kind of going to the next set of images here, okay. Here's an example of that exaggerated smile where the patient's chin is too low, okay. And it would be the opposite, right? If it was a reverse smile, okay, the patient's chin would be too high, right? If this was the opposite. Here's an example of a lead apron artifact. Okay, you're not going to be able to see anything. Okay, it is going to be very, very, very opaque. Okay, you're not going to be able to see any teeth behind here. Okay, and then here's an example of the air spaces, kind of what I was talking about. And it also looks like here the patient is also slouching as well. They're not standing all the way straight just because these mandibular anterior teeth are a little bit blurred. Okay. But here are an example of the air spaces. Make sure you know your air spaces and all the anatomy associated with panos. I'm not going to go over the anatomy of panoramic images just because I feel like there's a lot of anatomy to cover. So I highly suggest making flashcards or doing a lot of practice questions with that, because that would definitely be tested on the board. And so here is your palmoglossal airspace here, okay? And this is whenever the patient's tongue isn't touching the roof of their mouth, okay? So that's why we ask patients to lift their tongue to the roof of the mouth to kind of remove this airspace so you can kind of see the apex, the apices of these maxillary teeth a little better, okay? And then just knowing normal anatomy of x-rays is important. Here's a composite filling, okay? This looks like an amalgam filling here. But normal anatomy, you guys know your enamel, you guys know your pulp, your dentin, okay? Obviously this is bone, but just understanding like the bone between the teeth, okay? This flat bone here is called the cortical bone, okay? It's gonna be a very dense bone, and normally it's gonna be very, very white, okay? As we move anteriorly here, you can kind of see that the cortical bone starts to get a little darker. And then the PDL space is something that you also want to be able to recognize, okay? We do not see any PDL fibers in x-rays, okay? The PDL fibers are too small, okay? We don't see the actual ligaments attaching onto the cementum to the bone itself, but we see that PDL space where that would occur, and it kind of is between what's called the lamina dura, which is going to be the white part of the bone outlining kind of like the alveolus or the roots of the tooth. Okay, so this would be the lamina dura here, okay, outlining the tooth. And then between that, you're going to get your PDL space connecting to the cementum and connecting to the lamina dura. Okay, so those are some basic anatomy there for you guys to kind of understand as well. So, kind of going into the more not so fun parts of radiology. Okay, so there are different types of radiographic imaging. Now, I don't, just a heads up for you guys, on my board, I got no questions on film, and I believe the class before me, those second years, they also got no film questions, so I would not look at any film when studying for this board. I feel like you already have to know a lot, and trying to cram in film, um, would just add more to your plate. When I was studying for the board, I did look at film because I was kind of, scared. I wasn't sure if I was going to get any film questions, but I did not get any. So I would not look at film. Just low heads up for you guys. But there are other types of radiographic imaging though. Okay, so there's direct and there's indirect imaging. Okay, direct imaging is what you guys use in the clinic. It's gonna be most likely what you guys use whenever you go out and start working. Okay, and it's gonna be called CCD. Okay, and so you're gonna have your typical sensor. You're gonna hit expose, and then with direct digital imaging, no scanning is needed prior to the production of the photo onto the monitor. Okay, so whenever you hit expose, okay, the sensor is going to convert those x-rays into an image immediately, and it's going to pop up onto the computer screen. Okay, so that's direct radiographic imaging. Indirect is going to be whenever you're using a PSP plate, okay, or a phosphor plate. This is indirect because you produce a latent image. This image is not immediately projected onto the computer monitor. It actually needs to be scanned in prior, and then when it's scanned, then it can be produced onto the monitor. So the names kind of give it away itself, but I would associate CCD with direct digital imaging and PSP with indirect digital imaging. Alright, and then just knowing how the tube head works and producing electrons, converting them into x-rays, and then ultimately how it pops up onto the computer. Okay, so just to start off, you need electrons to know in order to produce the x-rays. Okay, so the image here kind of shows that. To the left, you're going to have the cathode electrode. Okay, it's going to be the negative electrode, while the anode is going to be the positive electrode. The function of the cathode is going to supply electrons to produce the x-rays. Okay, like I said, you need electrons in order to make x-ray photons, and so that's what the cathode is going to do. Okay, there's two structures. You're going to have the tungsten wire, which is essentially going to heat up. This is going to get very, very hot. Okay, and when this gets hot, it's going to produce electrons in this electron cloud. Okay, basically there's going to be a whole bunch of electrons, okay, in this area, and that's going to heat up, produce the electrons, and then you're going to have this focusing cup, which is then going to project or aim the electrons towards the anode, okay, towards this structure, and this is called the tungsten target. Okay, the tungsten target and the copper stem are both part of the anode, which is the positive electrode. Now, in order to produce the x-rays, okay, like I said previously, you need electrons. Okay, so the electrons are going to be aimed towards the tungsten target by this focusing cup. Okay, and the function of the tungsten target is going to slow down or stop the electrons. Okay, whenever the electrons are stopped or slowed down, you produce energy. Okay, this energy is then converted into x-rays, and so tungsten target is very important in producing x-rays because it essentially slows down the electrons to produce the energy to produce the x-rays, if that makes sense. Now, whenever you produce energy, okay, you're going to have a lot of heat, and so the copper stem is basically here to absorb the heat that is produced. 99%, okay, of the energy is going to be absorbed as heat, and then the other percent is going to be actually used to produce the X-rays. That is then going to come out of the actual tube, and then this is what's going to go through the teeth, and it's going to hit the sensor. Essentially, that's how that works. Okay. Now, you are going to have like a primary beam and a secondary beam. Obviously, the primary beam is going to be the useful X-ray beam, okay, that comes out of the tube head. Now, I also made a little note here to understand, okay, structures that absorb more X-rays are going to be more radiopaque, okay? So, enamel, okay, very radiopaque structure, okay, is going to absorb more of the X-rays than like dentin, okay? So that's why structures appear lighter or darker than others, okay? Now, here are the different types of radiation to understand. Okay, basically how we produce the X-rays. There's different ways to it. Okay, the most common, okay, and know this, the most common is going to be called general or Bremsstrahlung radiation. Okay, so high-speed electrons, okay, kind of what I was talking about, are stopped or slowed down by the tungsten target. Okay, that's basically what I was just saying earlier. Okay, it's going to be the most common type of mechanism to produce your radiations. Okay. Now, for characteristic radiation, okay, the bombarding electron from the filament will collide with another electron at the tungsten wire. Okay, this one's going to be a little bit less important to understand, but kind of understanding that this is going to be the most common and kind of how these two work, okay, are important tidbits to know. Alright. And then you're also able to change different factors, okay, when taking X-rays. And so there are different ones, okay. So you have kilovoltage or kVp, or you have milliamperage, which is also just MA, okay. So kVp is going to determine the speed of the X-ray and the quality of the X-ray. Okay, so determine speed and quality. Okay, if you increase kVp, okay, the quality, and increase quality, and you're going to increase the X-ray speed, resulting in a darker image. But if you decrease kVp, you're going to have a lighter image because the X-ray is aren't going to be traveling as fast. Okay, this is an important concept to know. Okay. And how kVp in its relationship with contrast. kVp has an indirect relationship with contrast, meaning if you increase one, the other one's going to go in the opposite direction. If you have low kVp, you're going to have high contrast. Contrast is basically the idea of separating the subject from the background, okay? So if you have high contrast, you're going to be able to see the subject a lot better than you can see the background. Okay, so low kVp equals high contrast. This results in few shades of gray. Think about it. If you have lots of shades of gray, you're not going to be able to determine the subject from the background. Okay, there's going to be a lot more grayness involved in the overall image. Okay, so that's why high contrast, few shades of gray, and because you have fewer shades of gray, it's going to be short scale. Okay, short scale contrast. Opposite with high kVp. Indirect relationship, high kVp yields low contrast. Because you have low contrast, the subject kind of blends in with the background, and so you have many shades of gray, okay? And then because you have many shades of gray, you have long scale contrast. So that's kind of how this relationship works, and really understand this part right here. Okay, and milliamperage or MA plays a big part too. Okay, and to understand what MA does, focus on the A. Okay, I like to correlate the A with amount, and so you're determining the number of electrons produced or the quantity of the electrons. Okay, obviously you need electrons to produce the X-rays, so if you have more electrons, okay, you're going to have a higher number of x-rays. And so if you increase MA, you're going to have a darker image, and if you decrease MA, you're going to have a lighter image. And just know that exposure time is going to be the easiest to manipulate or to change out of these factors. And I guess we're going straight into tissue sensitivity. I don't really remember how my slides are organized, but this is an important topic to know too. Okay, so anything really, I feel like this is kind of self-explanatory if you really just think about it. Anything with blood or thin tissues is going to be more sensitive, and so blood is going to be very sensitive to radiation. Bone marrow, okay, this is kind of where your blood cells are produced, okay, very sensitive to radiation. Reproductive tissues, obviously sensitive, and then your oral mucosa, okay, is going to be sensitive, okay. Kind of think about like radiation, head and neck radiation, and like oral mucositis, okay. Your oral mucosa is going to be very sensitive. Now your least sensitive tissues, very dense tissues, like organs, okay. So bone, least sensitive, okay. Nerve, muscle, thyroid, and kidney and liver, okay. So I feel like just these are pretty easy to think about. And diving into the SLOB rule. And so SLOB stands for same lingual, opposite buccal, and this is kind of to identify different artifacts that may be stuck in a patient's mouth, okay? So taking x-rays is going to be a good way to determine if it's on the buccal side or if it's on the lingual side. And so let's say my cursor was the artifact, okay? Right here. So if I took an image of this and I took another x-ray and the artifact went the same direction, then it's going to be on the lingual side, okay? So let's say I took a more anterior bite wing, okay, and the artifact moved anteriorly as well, it's going to be on the lingual side. But if it moved in the opposite direction, the artifact is going to be located on the buccal side. So if I move the x-ray to the right and the object moved to the left, okay, buccal. If I took another x-ray to the right and the object moved to the right, it's going to be on the lingual side, okay? So that's what the SLOB rule says. Alright, and I believe we're going to go straight into the difference in filtration and collimation. And so filtration, right? What is a filter? Okay, so a filter helps remove anything that you don't want. Okay, so filtration in the X-ray tube, okay, it's gonna be made out of aluminum to remove any long wavelengths. Okay, so you really only want that primary beam, okay, and you don't want really any of the secondary beams because that's just gonna cause more radiation to the patient. Okay, so if we go back to this slide, okay, you're going to have the useful X-ray beam, okay, and then you're going to have the secondary beams that aren't really going to play a part in creating that image. And so sometimes you're going to have a filter here to filter out these secondary beams so we can really isolate this primary beam, okay, to basically reduce patient radiation exposure, okay. And like I said, that's going to be made of aluminum, and you must have at least 2.5 millimeters of filtration. Okay. Collimation. I know you guys are very familiar with your collimators in clinic, probably. Typically made out of lead, and it's to determine the size of the beam and the shape of the beam. Okay. So here's an example of a round collimator here. So you see kind of how it restricts the size of the beam as it goes out. Okay. There are two different types typically, so you're going to have typically a round collimator or a rectangular collimator. When I was at Parkland, there was the rectangular collimator, and this one's actually going to be the best in changing the shape of the X-ray beam. Okay, so here's a good image here. X-ray beam for cylindrical collimation, kind of see how it diverges more outwards. Rather, if you have the rectangular one, okay, it's not going to diverge as much, so it's going to be more effective in producing that image for you, okay? And this collimator, okay, cannot exceed 2.75 inches. Principles of shadow casting. Okay. When I learned this for the first time, it was very confusing, but if you think about how you take x-rays, it's a little bit more easier to understand. So you want a small focal spot, okay? That's why a rectangular collimator is going to create more of that smaller focal spot, okay? The x-ray beams are going to be more concentrated in a smaller area, creating a more detailed image, if that makes sense. You don't want a large focal spot, okay? You want a very small one, so it creates that detailed image. Long target object distance, so you want the tube head, okay, that's why we kind of add the PID or the collimator, okay, to create that long target to object, target being that PID, object being the tooth, okay. That's going to create a more detailed image, and it's also going to reduce the penumbra or the blurriness of the X-ray, okay. You also want a short object to image receptor distance, okay? So whenever you're taking a bite wing, kind of think about where you're placing that sensor, okay? Object to image receptor. You want the receptor to be as close to the object, okay, as you can, okay? So you don't want to place the receptor on the opposite side of the mouth. That wouldn't make much sense. You want that receptor to be as close to the teeth as possible. Now you obviously want the object to be parallel with the image receptor, okay, because you're gonna want that beam to be perpendicular, okay, to the teeth and the receptor, okay. And ultimately, this is what's gonna cause a lot of that overlapping, is if the beam isn't going to be perpendicular, like perfectly perpendicular to the contacts of those teeth, okay? If it's not, then you're going to have overlap. And then next, just really talking about short and long-term effects of radiation exposure, I guess. So short-term effects, obviously, you can have a very large dose in a very short amount of time. Think of like acute, okay? If something's acute, it hasn't been going on for very long, okay? So effects, right? Very common effects, okay? Redness, nausea, vomiting, okay? Something called acute radiation syndrome, okay? I think some other effects could also be, I think like hair loss, diarrhea, vomiting. Well, vomiting's on here. So those are some other short-term effects of radiation. And then long-term effects, right? Small doses repeatedly, okay, over numbers of years, okay, for a very long time. And an obvious one for a lot of chronic conditions is going to be cancer. Types of X-ray interactions. I probably should have put this one before those other slides, but this is going to be okay. So just knowing the types of X-ray interactions and knowing its percentages, okay, and also knowing its percentages, you also know which one's the most common, okay. So 8% of the time, the X-ray is not going to interact with anything, right? So in this image, let's say my cursor is the X-ray. It's going to go pass right through the atom unchanged, okay, right through. It's not going to interact with anything. Coherent scattering. The photon, the X-ray photon, is going to collide with an electron, okay, causing the electron to vibrate, okay, to produce an unmodified X-ray photon in a different direction. Unmodified is going to be the key word here, okay? The energy that the X-ray photon came in with is going to be the same as it left, okay? As you can see in this image, scattered photon with same energy. That's coherent. That's going to occur 9% of the time. Photoelectric, okay, is whenever you're going to have an X-ray photon, okay, starting off the same here, is going to collide with an electron in the atom, okay, but it's going to eject it from the atom itself, okay, so that's photoelectric. It's going to scatter that electron. Compton scattering is whenever you have an X-ray photon and you collide with an electron again, but you produce a modified X-ray photon, okay? So this Compton scattering is the exact opposite of coherent scattering. Coherent produces an unmodified X-ray photon. Compton scattering produces a modified X-ray photon with less energy than it came in with, okay? So kind of look at this and kind of understand the definitions, okay? Because this will probably be tested on the board as well. And know its percentages. Now there's different techniques of taking x-rays as well. Basically out of these two, just know that paralleling is going to be the best option majority of the time, okay? It's the technique that you guys use in clinic, okay, and are taught. And so with paralleling technique here, the beam is going to be both perpendicular to both the long axis of the tooth and the image receptor, okay? That's kind of what we were talking about earlier with the shadow casting principles, okay? We want that beam to be perpendicular to these structures, and we want the image receptor and the tooth or the object to be parallel with each other. Now the bisecting angle technique, okay, kind of the same, but instead of being perpendicular to both the tooth and the image receptor, there's going to be an imaginary line bisecting both the image receptor and the tooth, indicated by this green arrow here, okay, and then this beam is going to be perpendicular to that line, to that bisecting line between the tooth and the receptor, okay? So that's the difference between these two techniques, okay? But most of the time, this is going to be the most common and the best. Okay, direct and indirect theory, basically how x-rays interact with our cells and chemicals within our body. And so when it's direct, okay, the x-ray is going to interact with the actual chemicals in our cells, specifically with like the DNA, okay, or like the ribosomes, or with specific organelles in our cells, okay? It's directly affecting our cells. Indirect theory is whenever you're going to have the x-ray is going to ionize water, basically going to change water, okay, to form what's called hydrogen peroxide, okay? And then this hydrogen peroxide will then interact with the different chemicals in our cells, okay, to produce a change, okay? So so the x-rays are indirectly affecting our cell chemicals by producing this structure right here, okay? So that's why it's called indirect. That's why it's called direct and indirect. And knowing MPD, maximum permissible dose, is important. Obviously occupational people who work with x-rays all the time, okay, we're going to be exposed to more radiation than other people, okay? So for us, in other occupations where you work with x-rays, okay, 5 rems a year or 0.05 sieverts, okay? If you remember this, remembering non-occupational is going to be a lot easier, okay? Remember one or the other, okay? Non-occupational are going to be people who don't typically work in a field where you need to be exposed to x-rays a lot, and so you just basically just add a 0, and so instead of 5 rems per year, you're going to have 0.5 rems per year, okay? And instead of 0.05 sieverts, okay, it's going to be 0.005 sieverts, okay? These are basically the same, you just basically convert them a different way, okay? So it's different units, essentially. Okay, we're allowed this much we're allowed this much radiation per year if you're an occupational worker or if you're non-occupational. Now you're automatically going to be included in the non-occupational if you're either pregnant or if you're under the age of 18. So know those numbers, remember those numbers. Now the inverse square law basically explains the relationship between the intensity of the radiation and distance. And so obviously the further the distance, okay, the less intense the radiation is going to be. Okay? And so for example, if you half the distance, okay, half the distance is going to be inversely proportional to the intensity. So you're going to take the inverse of this. So instead of it being 1/2, it's going to be 2. Okay, and you're just going to square it. So if it's half the distance, it's going to be 4 times as intense. Now, if you increase the distance 2 times, okay, it's going to be 1/4 as intense because you're going to take the inverse of 2, 1/2, square it, it's going to be 1/4. Basically, just understand if you increase distance, the intensity of the radiation's not going to be as strong or intense. Vice versa, if you decrease the distance, the intensity of the radiation is going to increase, okay, inversely. And then there are other extraoral imaging as well. I know that there's like occlusal imaging, but the one that will probably be on some of your boards is going to be just the Waters projection, okay? And then this is basically going to evaluate your maxillary sinuses or just your sinuses in general, okay? So this one's the one that I feel like is be important. And also just knowing like the reasons why we take certain x-rays. And so like for like a pano, right, you're not going to take a pano to really evaluate caries, right? That's just not the most ethical or like best way to do that, right? You're going to take a bite wing for that, okay? And so for like a pano, you're really going to take a pano to evaluate like eruption patterns, or like TMJ is also going to be one since it takes an image of the whole jaw. And obviously like bite wings are going to be very good for caries, and obviously PAs to see the root, to see if there's any like apical radiolucencies that might be present. Oh, and to really quickly go over this important topic, okay, vertical and horizontal bone loss. Okay, so horizontal bone loss is going to be an even loss of bone from CEJ to CEJ, okay, and vertical bone loss is unequal loss of bone from CEJ to CEJ. But an important note, okay, to take into account is the cortical bone typically travels from CEJ to CEJ. So if we look at this second premolar and this first molar, okay, this first molar CEJ is lower than this premolar CEJ. So typically what's going to happen is the cortical bone is going to travel like this at an angle, okay? If you see it traveling at an angle like this, that's not vertical bone loss, okay? If that makes sense, okay? It needs to be a clear loss of bone. Just because it's traveling unevenly and it's not flat does not mean you've lost bone in that area, okay? And really, I think for the most part, those are some of the more important topics in radiology. Obviously, look at your normal anatomy, because I feel like that's 100% going to be covered on everyone's board, okay? no matter when you take it. And so, yeah, if you guys have any questions, don't, feel free to reach out to me. Like I said, this is my first time making one of these videos. I plan on making more on some other topics as well that will definitely be covered on the board. So if you guys have any feedback, let me know. The beauty of making these YouTube videos is you can always re-watch these and pause them whenever you need to. And so just good luck on you guys' studying. You guys will do great. I know it's a lot, but just take it one day at a time and keep grinding. So thank you guys.